Yeah, good. Give it just a minute for the virtual thing to get kicked up. All right. Yeah. Good. All right. Good afternoon. Hello, everybody. I'm Walter Thornton, I'm a psychiatrist here at Walter Reed, for those who don't know me. This is also being broadcast on TV, so while I'll talk to the people in the room, I'll also talk to the virtual world. I'll have some interactive bits. So I'll shout like this so everyone in the back can still hear me. Because later on, like some of the last year, we'll have some participations and changes. Go ahead. All right, go ahead, next slide. All right, so the relevant disclosures, I have none to attend. Admittedly, this is my interpretation and attempt to find the regulations and provide guidance accordingly. But in the end of it all, I'm human. These are not direct reflections of the policy of the DoD. These are my interpretations and finding the regulations for today. All right, so let's review very quickly where we're at in the military curriculum. So remember that we go through these different competencies and domains in our curriculum. And the bottom left corner, that's what we're talking about today. Duty limitations, e-profile, and med board, the other administrative and medical tasks that we might have as active duty providers throughout our careers. Next slide. So my goals for today, I want to start from basics. We'll talk about what is an ADSET versus a med board, for example. We'll talk about the basic medical retention system, profiles, those type of things. We're going to try to cover for multiple services as well. So we'll cover limited duty, light duty, limb duty versus med board and U.S. Navy as well. And then I want to build it up to describe the rules and regulations related to that process so that you know how to find those same regulations I went to find in order to make this presentation. So that someday when you're alone and off in the world and you're trying to figure out what to do, you know where to go to reference. Then we'll kind of demonstrate how to assess whether or not a service member has met the medical retention determination point. And we'll talk about when to consider med board versus ADSET or administrative separation. We'll describe the process of initiating a medical board, describe some special rules. Then we'll do that again for the U.S. Navy, U.S. Marine Corps, and then we'll run through cases and examples of the Go ahead. All right, so for those here at Walter Reed, this is our current website. Admittedly, this is the first place I went when I got set up for this presentation, because you see right at the bottom there, Army e-profile, Navy LIMDU, Air Force ASIN, and it has several different links to a lot of the different regulations that I use to build this procedure. So for those who aren't aware, capitalpsych.org, mill readiness, you can use that. Other things I end up doing within it, going like Army publications and pulling up the website and pulling the original publication, make sure it's up to date. The stuff get verified, maybe the regulations changed over time, or other different websites like that. Next slide. All right, so for review, last time I was up in front of y'all and I was talking about this stuff, we went through e-profile. So some of this should be just quick refreshers. It's been a good couple months since we talked about it. So remember that e-profile is the Army's electronic system for documentation of medical and psychiatric profiles. It's where you write down the details, the limitations, the things you want to have occur for your patients and service members so that they can take that back to the command. Because you just telling them, hey, I want you to wear this wrist brace for a week, doesn't mean necessarily the Army is going to understand that they're supposed to have the wrist brace. Sometimes they need a profile of documents. I want them to do the following and not do the following. Additionally, these regulations are covered under AR 40-501. That right there is kind of the main answer key for a lot of what we're talking about today. So later on, when we're doing interactive cases, and you want to double check yourself before you raise your hand and say, I think we should do this, you could quickly pull that out and double check.
Can you use the microphone, the handheld one up there? You're gonna have to turn it on.
Hello.
Is that better? All done?
No, talk quietly.
You can pull it down.
Can you hear me now? I apologize if I was screaming at everyone a second ago. I'll try to talk quietly into the microphone instead. So as I was saying, AR 40-501 is one of the main resources I use for the presentation. And later on, when we're going through cases, you yourself might want to pull up some of those segments. Although we will have some other cool tools embedded in the slides to help you out there. We already talked about communication with command, and then recall that we're providing recommendations to our units and commanders. In the end of it all, command authority to decide on take that recommendation. Sometimes the mission may outweigh your desired profile. However, we can provide information to our commanders to make future decisions, and sometimes potentially the commander to prevent putting a service member in a situation that would make their condition worsen, knowing that they had the things we were diagnosing and treating start. Next slide. Next. All right, so before I click next, who remembers the two main types of e-profile? Two types of profile. Go ahead.
Temporary, permanent.
Perfect, thanks so much. So the temporary, remember limitations up to 12 months, typically 30 to 90 days being the most common. There's also some guidance to reassess your profiles routine as you're undergoing treatment. Versus a permanent profile, it's when new limitations are going to extend beyond the 12-month period. Now, notably, as we'll talk more about later, this is also when we expect the service member will not recover back to an ability to return to duty during that time. Profiles expect rate is deployability. Like I was saying before, we can sometimes use them as a way to gauge who should be going where, so our commanders can actually make informed decisions on which service members are ready to deploy overseas, for example. And then a permanent profile may require approval from the medical board, which is what the main topic of the session is going to be today. Next slide. All right, so when should you be assessing someone for a profile? This is also not a rhetorical question. What's the answer? Every visit. It's like I planned to the audience. Good job, personally. I appreciate it. So at every behavioral challenge, especially, obviously this is targeted for behavioral health profiles in the board in particular. Go ahead, next. So we need to consider placing anytime we're changing medication. For example, if you start Cymbalta today, do you want them to go into the insert country here tomorrow? These profiles are a way of communicating that information to command as well as providing medical recommendations, right? Changing doses, psychiatric hospitalization, et cetera, et cetera. Every time we're affecting someone's readiness under either their medical diagnosis or condition has changed, or we're concerned they would deteriorate because of their condition, or we have made a medical change that we would concern would not want them to do certain things. That's when we change and consider the profile. Next slide.
Landon,
Yes, sir.
do you want the PS gallery comments as they come to my mind, or do you want me to wait?
Go ahead, sir. Make it interactive.
So, just one thing, obviously, we try to weigh the amount of stigma that we may induce. So that initial thing about initiating new psychiatric medication, that should be more of a exception than rule. So most patients that we see as we start on new medications do not need to be starting on an profile, temporary profile. Exception might be I start someone on like an antipsychotic or lithium or something like that, where I definitely want the commander to know, because it would probably impact other things on the e-profile too. The other two big kind of check boxes there are if you don't want the soldier to deploy, or if you don't want the soldier to have access to firearms.
Yes, sir. Thanks, sir. And that was more kind of the details of what we talked about last time, was the what is appropriate versus inappropriate limitations. I'm sure I'm jogging some of y'all memory last time. Can't tell them that they can only work from 10 a.m. till noon once a week. We need to provide other alternatives more appropriate. And basic command can actually use, right? All right, next slide. There's one more blurb on the slide. Basically, you should at least consider it, not necessarily initiate, but consider based off of any time you're making changes, you should be thinking through readiness, because the main priority is readiness. You should treat each encounter as a readiness encounter. Remind yourself where they're at in the treatment process and what tomorrow might look like for them if you chose to not initiate a profile. Next slide. All right, so now we're going to move on to what we're actually talking about today. When do you refer someone to a medical board? I'm okay with this one being rhetorical unless someone already has a really good answer. So there are two conditions. Number one is when a service member has a condition that is disqualifying. That's a direct quote from different policies. These conditions are listed in that policy right there for the U.S. Army. Like I said, that changed for later. I also brought up the man-med for the U.S. Navy right there, just in case you need these when we're going through cases. So they, one, have a condition that has been deemed as potentially disqualifying, and two, go next, the medical retention determination point has been reached. So we're going to first review point one before I give you a better definition of the medical retention decision. Next slide. All right, go ahead. So why medical board versus administrative separation? One of my goals here was to not put the cart before the horse and run straight to med boards. I thought we should take a step back and talk about what is an ADSET and what is a med board. You can go ahead and hit next. So the military has certain requirements of all this. Every single person here who joined went through some form of commissioned physical or some sort of enlistment physical and all the above. You were assessed for your ability to do your job from day to day. Go ahead and hit next. However, that doesn't mean we'll always be able to do the jobs we're assigned. Sometimes things prevent us from continuing our duties, either a medical condition or perhaps otherwise deemed misconduct. And sometimes our definition based off of DSM diagnosis of conditions and misconduct might differ when we get into military regulations. Anyone think of a DSM diagnosis that typically ends in administrative separation instead? Oh, judgment disorder, exactly. We're actually going to run through here in a few minutes. That's an example. So you think medical condition limits duty performance, that does not mean medical board by default. Certain things may lead to administrative separation, or like say, for example, personality disorder, right? All right, next. So notably, what is the difference between medical board and ADSET for the service member who is separated? We at the medical team and working with our commanders say, hey, this service member needs to leave service. We recommend the following. When you recommend a medical board, realize that you're recommending that that service member has a condition that is going to be provided long-term, say, financial or medical incentive. They're potentially going to get a VA disability rating. They're going to get continued medical care. And let's be honest, perhaps there's some conditions that occur during service in line of duty. We should be paying, providing services. There are other conditions, say they joined with pre-existing condition, say they had other forms of misconduct and went through administrative separation. That in itself does not mean they get 100% disability rating and VA price. But I want to clarify right here now, I'm assuming, just in case anyone had already was confused about it, ADSET does not mean necessarily medical benefits. And then, of course, someone who gets ADSET might later go to the VA and be able to claim disability. It's a lot harder in comparison to doing it before you get out. And realistically, this is the system we're trying to sell. So when you're weighing these cases later on, following the rules and regulations, and then weighing that in your head and realizing why someone might want one or the other. Another big key point is the time it takes. Adjustment disorder was the example we had earlier. Sometimes an adjustment disorder is they are allergic to the military, allergic to the army. That means the sooner they get out of bed. ADSETs do technically tend to take less time. And sometimes your patient knows that before you talk to them. So they're talking to you about how they can get set up for an ADSET when you're investigating if they have a condition that might be a medical. That's I am.
Yeah, just something worth considering. Most of the patients you'll work with for military disposition will be enlisted. The rules are different for officers. This is something we see a lot more rarely, so I'm not as experienced, but just something to keep in the back of your mind. If you're working with an officer, the kind of chapters and rules that apply might be different.
Agreed, and I'll make a quick comment on that. Later on, we'll talk about how to do a med board well, and not just initiate a med board. And I would argue refreshing the appropriateness of your situation, but rank, reviewing the regulations and details, because as you're mentioning, it might be different depending on if they're enlisted or officer or in the Navy or in the Army.
When a service member gets ADSEP, do they get any psychiatric support from the VA? So say they get ADSEP for an adjustment disorder, will they get any continued treatment for that? Or if they get ADSEP, they get zero psychiatric support at the military?
So I'll answer your question with more of a story / scenario. It depends, because what if they have another reason why they might get continued care? If you're administratively separating someone for an adjustment disorder who's been in for, let's say, a year, no deployments, no other notable medical conditions, no other reason for continued care, the answer is probably no. Anyone feel free to correct me if I'm wrong. But if you ask someone for an acute adjustment disorder, total time service 1 year, no deployments, what is the limit?
So they can still go to the VA for care, and the VA can effectively offer them a second opinion, you might say, just because no active duty provider said they have, for example, PTSD. They can go to the VA and say, I have these symptoms. The VA can still treat them and even give them service connections for them.
And will not guarantee you will help with that. Having talked to some of my friends who've gotten out, just because you go back to a VA does not mean you will get care. If you do the assessment beforehand and move them forward, and then will. Another quick caveat before we move to the comments that we're waiting for, is also if deployed. The VA for a while was providing 4 years of medical coverage, effectively 100% disability for anyone deployed during that. So that'd be another reason why they might get additional.
There are other layers of or two, so a lot of states have their own, VA system, so we're talking about federal system, but some states have very veteran-friendly, policies, and I'm from New York, and I get these constant letters about how I can come and get my primary care done if I have served a month or more, so there's so it all depends, and as we go into the discussion, it's sort of in the back of our mind, but when it comes to determining medical determination point, it's much more clear than deciding, yes, well, that's really not our job in terms of what kind of benefits they get, et cetera.
I was gonna say 30% is the disability rating that would qualify you for VA care. So if you had any conditions that answer 30% during service, you can get care. And I agree, it doesn't change in the end of it all whether or not they have impairments and limitations in our active medical retention decision point. But it is something to be aware of as far as the motivations and perspectives of our service members and patients when they come to their office. Because they're aware of this. They know what's going to provide a medical care or not, potentially. They know how, they might, or they might not know these things. Just be aware of these things when considering it. Next slide. All right, so this is where we start reviewing the medically board of psychiatric conditions in particular. This is from the regulation I was citing before. Go ahead. So psychosis disorders, the psychotic features, I think that one's not necessarily a shock. There's a few when we get down the list that I'll ask some questions about. Go ahead and hit it for you. Bipolar, PTSD, major depressive disorder, anxiety. Stop me if these seem like a surprise to you. OCD dissociative, and stop. Somatic symptom and related disorders from the DSM. There's one notable diagnosis in that category that is not a med-boardable diagnosis. Anybody know what it is? There it is. I heard malingering first, which, to be fair, it's not under that category. It is in the DSM, sadly, it's not. We'll save that for another debate. But factitious disorder in particular. And why would factitious disorder not be a med-boardable? Some of the diagnostic criteria has to do with falsifying or providing these details, right? There is some underlying this medical condition, right? Everyone know what I'm talking about? Next slide. Neurocognitive disorder is medically boardable, and chronic adjustment disorder, but not acute. This is my other question. What's the difference between acute and chronic adjustment disorder?
12 months.
Right, 6 months, 6 months, exactly. So, but it is notable that chronic adjustment disorder is a med-boardable condition. So those are the two that I keep in the back of my mind, because really what I think through is I think of this list, I think these major conditions that occur after a period of development, after the joint service, that could be potentially service related. Minus if it's factitious or acute adjustment disorder. Those are what I think are preventable. But then at the end of it all, before I click any button and make any changes, I always check the regulation and make sure. Next slide. On the other hand, these conditions, psychiatric conditions from the DSM that do not receive a medical board. Factitious disorders / malingering, personality disorders have a separate chapter, substance use disorders, acute adjustment disorder, ADHD, impulse control, other things like that. Because like I said, in my cognitive way, the way I think of it is things that either occurred or got worse during service. Those are the things that we're looking for med board versus administrative separation. They had ADHD from when they were a kid and they don't get compensated. Perhaps we should be med board. All right, next slide. So where do I find which conditions are medically boardable or not? Once again, the regulation from before. In fact, I actually went ahead and pulled out the text, which you can read if you would like to, but it just reminds you that we provide the behavioral health evaluation, include these different disorders, we look for these things. And one of the phrases I've heard in trainings like this in the past is the burden of proof. So which way does the scale by default tip? And technically it's designed in such a way that we should be accidentally, theoretically, it would be argued better to accidentally give someone a diagnosis and condition versus missing something, because say PTSD when deployment or something along those lines, and adds it. So it's on us to prove that they do not have a medically boardable condition. Document, we screen for X, Y, and Z in our notes. We recommend administrative separation or safety. All right, and then also we'll review some naming policies here in a little bit. Next slide. So now we're gonna talk about the medical retention determination point, which just by looking at the words, you can kind of in your head figure out what we're talking about. This is, go ahead and hit next. This is when they've had that condition and then either within 1 year or after 1 year, it does not appear that they're going to be returning to a state of being able to return to duty. Next. They're gonna need duty limitations such as like weapons restriction, non-deployable, other things that may or may not be compatible with their particular job. If continuing military service is also, there's a blurb in some of the regulations that say it's not in the best interest of the US government. No, you do not have to wait a full year. That's why I'm saying if it's looking like, say you're treating for somebody and you're going through multiple modalities of treatment and things are not necessarily recovering the way you'd expect, you can start approaching the conversation with med board 5 months into treatment. There is no necessary. That's kind of provider judgment. That's your job. So you take these regulations, you know what the end result is, and you figure out when is the appropriate time to initiate a medical board versus other things. Next slide. All right, so if a service member is at that medical retention determination point, we then decide whether or not they should be referred to a medical board. If the psychiatric cause is the cause of the impairment, it does not, just to clarify, that means that someone can have, say, major depressive disorder and then have another problem that's impairing their ability to work. And if you, as their psychiatrist, determine that it's not related, the problem, say, for example, is UCMJ offenses or misconduct or other things like that unrelated to the diagnosis, then it doesn't meet criteria. What we're talking about here is that their impairment is the anhedonia and the difficulty getting out of bed and going to work, and that's why they're showing up to PT late. That, on the other hand, might be a medical board. Impairment or further duty limitations can be a reason for sending them into a medical evaluation board, with one exception that we'll talk about in a minute. However, most of the time, if someone has a impairing condition, they're going to need duty limitations. Does not necessarily, it has to be that way, but typically, most disorders have conditions that say occupational, interpersonal, leisure, and social. Military service is their occupational, interpersonal, leisure, and social experience. So if they have the criteria for the disorder, they're probably having trouble at work as well, but not always. All right, and then prognosis poor, as in unlikely to return to full duty. Not prognosis is poor as in they're going to be depressed and dysthymic for the rest of their life, but prognosis is poor as the military service might not be the best choice. Go ahead and next. This is my next quiz note. Which one of the conditions requires both duty limitations and impairment? Even though I just said most of the time you have both anyway, one diagnosis requires both. You have to prove both. What is it? Go ahead, sir.
Can you define the difference between duty limitation and duty impairment?
Sure. To clarify for anyone who might not have heard it a few seconds ago, impairment versus limitation. So impairment is that diagnostic criteria is the way I think of it. In the DSM, it says difficulty with their occupational, interpersonal, leisure, social, affecting their ability to live their life, affecting them in some way. That's the impairment. Duty limitations are how that translates to their ability to do their job. And the example I was giving of the one that I like to use in my head is anhedonia from depression leading to somebody slowly not arriving in formation on time, not showing up to PT, getting in trouble at work for things like that, not doing their job and turning assignments in on time.
Okay, can I add to that?
Yes, sir.
So duty impairment is what the disease does to the person, right? So they can't think, they can't sleep, so they can't function in their job, etc. They're falling asleep, getting into accidents. Duty limitation is what we do to the person. But you may have a disease, and then I may put you on a temporary profile, which says you can no longer carry your firearm. Nothing about major depressive disorder prevents you from lifting a 7-pound firearm, right? But I'm imposing that on you. So e-profile would be a limitation, but that's important to utilize e-profiles because then you're able to check one of the boxes for that medical retention determination point. You know, that they have been on a temporary profile for 4 months now for firearm or for non-deployment. And so you're able to then show that that person have had limitations. In addition to any duty impairment. Any question about that?
Thank you for clarifying, so, because here's my definition was not complete. In fact, I would argue I was wrong. I didn't realize that the limitations of the things we're doing, the profile, the details.
limits we put on.
Limits we put on them.
Our policy.
All right, and then unfortunately, my best question of the whole PowerPoint, I'm almost done, just so you know, we're gonna start talking about Navy here soon. Chronic adjustment disorder requires both of those things. I'm not sure if that necessarily or why that was written into regulation. Every rule is made because of a reason. So maybe you can come up with a reason as to why that might be a requirement, but it is the only diagnosis that requires both. Next slide. All right, so how do I actually refer? I've got a service member who's at an MRDP and I want to refer them to med board. What do I do? Go ahead and click next. The Army, this easy. You open up that e-profile system, which of course, based off training last time, you've now got access to, you're familiar with it, you're ready to use it when you need it in the next couple of years. And you click on temporary profile and you convert it to a permanent profile. That's how in nuts and bolts as far as how to do it. But what I actually want, one of my goals, is to take any intern here, pick one, and have them go from 0 to doing this well. So I'm now going to give you the, in my opinion, advice on how to actually do this process. Go ahead and click next slide. Also, thank you very much for clicking next. I thought I got clicker. All right, how do I initiate it? Well, step one, use your resources. I've hinted at this a few times through the process. Having these regulations saved and knowing where to find these regulations, knowing which people to go to. If I had concerns, for example, Colonel Lamine is right down the hall, I might go to him and ask him these questions. Or maybe even Zach Monahan is going to present here in a few minutes. He's, I don't know, like 100 some odd med boards more than me. 70, I apologize. So anyway, let's talk about the board and confirm that they no longer meet retention standards, pull the regulation, make sure something hasn't changed. I don't just instantly hear chronic adjustment disorder, 6 months time, MRDP, click the button. No. You hit a pause, make sure you're right before you move on. Next. So after you do that, you go to your peers, talk to people who've done it, then you document your key points in your referral note. And I've heard this called other things at other duty stations. Referral note, final note, terminal note, whatever word you want to use. It's code for the note that the med board's going to look at. Because what is a medical board, but really a board of people who haven't met your patient, or maybe some of them have. They go through and review your alta records, your details. They look at what conditions were diagnosed when, what treatments you provided and when, and assess whether or not it's appropriate to medically board the service member under all kinds of different reasons and why. That's not our job, that's their job, they do that. But you can write some things in your note to make their life a lot easier. For example, if I'm getting ready to do a med board, I would go through and explicitly write down date of diagnosis, say with PTSD, which criterion were met when, which criterion were omitted with this treatment, which continued and persisted that are leading to which duty limitations, for example. Details, including the prognosis, where I explicitly state that I do not expect they'll be able to meet retention criteria within a year, etc. And some of these examples in Word documents do exist out in the world. So if you followed step one, they probably provided you a, hey, here's what I use for that condition. Here's some details that I would make sure are in my note. And then you complete step two. All right, step three. Inform the soldier. And this one is one of the ones that I feel like is kind of almost my favorite / most important. Because you can do these other things, you start the process and then click med board and never tell the service member. And I feel like that's just wrong, in my opinion. Again, not my opinion, I apologize if you have a different one. But I think from then you bring the soldier in and you say, hey, we've been treating your PTSD or whatever this condition is for this period of time. I don't think you're going to be able to return to full duty. I do think a medical board might be the right choice for you. Ask them what they know about that medical board process. Tell them and clarify details with them. Ask them to kind of repeat and understand. And then last but not least, do your risk assessment of that assessment. I'm sure all of you know, because you work in behavioral health, transitions can be a big deal. The day where you get the, you're going to be med boarded can be perhaps the best day of some service members' lives because being in service has been so difficult for them with this condition. And maybe the worst, maybe some of them were trying to downplay it, hide it, and never went to see the doctor in the first place. They were worried that you were going to kick them out the second they walked in your door, and their friend is the reason why they came in because a friend made them do it. Stuff like that. So either way, at that point, because this preemptive transition, and you're the one presenting it, you would then do another risk assessment, talk to them, make sure they're safe. Next. We've done step 1, 2, 3, 4, and then that's when I pull up the permanent SB profile and bulletin profile and initiate the medical board after I've prepped for that medical board. And then inform the commander directly of the decision and recommend duty limitations or changes of profiles, whether it be a command call or at the very least an email, reaching out as well. If you're working in an embedded behavioral health clinic, you likely have a meeting or a regular time where you go and work with your command team, at which point in time they were probably already aware that you're preparing to initiate a med board. Then you tell them you have initiated a med board and work with them. All right, and then continue treatment assessment during the medical evaluation board process. There's also, just to dispel any myth, you don't click the med board and then shove them out the door. That's not ideal how this is supposed to be. We're trying to give them treatment. We gave them a trial of treatment and they got to a point where they didn't remit. You decided it's appropriate for you to med board them. And then you continue that treatment during the med board process.
Thanks, Len. I would just say I would strongly consider reaching out to the commander earlier in this flow sheet. Specifically because if you don't, then the only thing you kind of have to go off is what the patient's telling you as far as their actual duty impaired. Which in some cases, it might be obvious to you that their duty is impaired, but in others, it might not, right? And the patient may just kind of have low self-esteem, but when you talk to them, they're like, oh, like this guy's like one of our best guys, actually, we're shocked to be hearing from you. The first time they hear from you, you've already done this permanent profiling, it's very awkward.
Thank you. I 100% agree. I think I almost to the point where I jumped right past that point because in my head, when I diagnosed insert med-boardable condition here, I was reaching out to command team, asserting duty limitations, getting collateral, et cetera. But you're right, 100% correct. The command should not find out you're initiating med board after you initiate it. And I apologize if that's what it implied. Any other good caveats or anybody else have any good tips? Go ahead.
The other thing that for point one specifically, if you're lucky enough to work in the area where the med board office is close by, or that the clinic has a good relationship with the office, reaching out to them before actually initiating the P3 profile can be really helpful. Because they'll be able to kind of check the chart before the initial stuff goes through and say like, okay, this looks like a good med board, or like, no, there might not be enough here for it to be approved. So I know like for Belvoir, for example, you're like highly encouraged to reach out to them before starting a permanent profile.
That's another great point. You could always reach out to the individuals who are on the med board or your local liaison office and talk to them before initiating the medical board. In fact, the person who I stole the referral note comments from, that's what they did, because they reached out to that person, got the what do you need in these notes, and that's where these kind of notes started cultivating. Thank you. All right, so that right there, for everybody here, not just interns, that right there is tips and tricks, as well as the added tips and tricks of working with your command team, letting them know beforehand, consider calling the office before you initiate it. That's how you do it. Next slide. All right, now we're gonna talk real quick about some special exceptions, and then I'm gonna pass the microphone over. So for service-connected PTSD, there's a DoD letter of instruction that came out specifically related to PTSD and service-connected PTSD. You can hit next as well. Basically, this was a catch-all on prevention to prevent, say, someone from having service-related PTSD and then, say, a drinking problem, a DUI, or some other reason why they might be undergoing administrative separation, or other administrative separations for other medical conditions, or whatever it may be. It was a way to ensure that a trial of treatment and medical board is evaluated. Because keep in mind, just because a med board is initiated doesn't mean that they're going to be medically boarded out, right? They might find they're able to return to duty, sure. Or they might remove them from service. And an ADSEP might be initiated and they might be removed and they might not get that VA disability. And then they're at the VA knocking on the door trying to get in where we can set them up beforehand. So there's the explicit wording, you can read it for yourself, unless they're found fit for duty later, like they're able to recover, they're able to continue service, they can stay on service, and then later they get chaptered for insert thing here or administratively separated for something else. Unless that case, with a diagnosis of PTSD, is almost certainly going to a medical board. And there are other exceptions about certain like rank limits and double checking. That's above the scope of this lecture. You should just realize that if PTSD, med board, it's almost always. But
just wanted to add to that, so, in the Navy, anytime somebody comes for a final physical that's being ADSEP, there's a separate form you have to fill out, the evaluating provider for the final physical, screening for PTSD and TBI for this reason. So that would be in theory, that would be safety net, that if they got missed, they were being ADSEP, and they did have symptoms of PTSD or TBI, they would get called up with the final physical.
and was this final physical as well for like ETS physical, like grave service stuff?
Or was it that additional form of PTSD and TBI only for ADSEPs?
Thank you.
That is true in the Army too. Yeah, so there's four state functions essentially. So if I'm gonna separate someone, there's specific chapters where mental health evaluation is required. So then you go and that provider, then you guys might have done those as PGY 3s and 4s, right? Has anyone done those? Yeah, so then you opine whether or not they meet retention standards as far as psychiatric conditions go. Then they can go out and get administratively separated. But we have these forcing functions because historically, there was an issue maybe 15 years ago where a lot of people who might have had PTSD were accepting them essentially we were not keeping our promise to service members that served and were traumatized by 20-year close of war on terrorism.
Thank you. Next one. All right, so now for demonstration practice, this is the other answer key related. We'll quickly kind of talk through it and I'll do the crawl phase where I very briefly with you work through 2 quick examples. Then we'll turn it over to Zach Monahan, who will kind of give you more of a walking run through, and then we'll do cases. And before you know it, y'all will be med boarding and ad-stepping and making decisions. All right, so it starts up in the top left where you start with that initial qualifiers. If it's psychotic, it's quick and easy, you jump straight to MRDP, right? Psychosis or bipolar disorder, for example, makes that pretty easy. Moving down to that, do they have dysfunction from this medically avoidable condition? Yeah. Yes, we'll move to the top. I wish I had a laser pointer, that's what I need. Then you go from dysfunction, then you go to receive adequate treatment. So one of the things I've been glossing over until this slide is trial of treatment. One of the things that you need is to actually provide adequate treatment for the disease. You can't just say, hey, diagnosed today and then tomorrow. At least you shouldn't be. You as a provider should be using your clinical judgment to attempt to return them to duty. Say, for example, with MDD, it should be potentially more than one psychotropic, like more than one SSRI, or SSRI, NRI, or IOP, therapy, or multiple modalities of treatment to your discretion, of course. It doesn't exclusively say in the regulation, these are the appropriate treatment. That's your job as a doctor. That's your job as a provider. But then you go from there and you say, did they get the adequate treatment? If not, they're not an MRDP, you continue treatment. If they are, then you assess, are they going to recover within a year? And that's how you decide between ADSEP versus medical board. Let's say dysfunction due to medically boardable condition, you said no to that. Let's say it's a non-boardable DSM condition. So they do have dysfunction, they're having trouble at work, but their diagnosis is paraphilia or one of the other things we talked about earlier for administrative separation. You then are at this bottom left corner over here, and you have decided that due to that condition, if yes, you check, does it assign with, does it interfere with their ability to do their duty? Are they able to continue in service? Are they able to return to duty today with the diagnosis on their chart that is potentially administratively separatable or not? And then you assess whether or not certain paper trails, given opportunity, command support, having those documents from the command saying, you know, we gave them trials of treatment. We tried to make, you know, we followed duty limitations and profile. We tried to help them however we could. Say, for example, somebody just had a specific phobia, for example. So you took steps to decrease their exposure to that phobia, but it started to get to the point where it was interfering with their ability to continue. Stuff like that. And then you go through and you look at one more treatment modality and you consider it in the bottom right here, DA 3022 7771, engage command for ADSEP under whatever chapter is appropriate. And we're not going to review ADSEPs today explicitly. That's another lecture we're going to cover on a different day. Just be aware that there is that option. And then what's the big difference between MedBoard and ADSEP? We talked about different things and trials of treatment and treatment after, right? All right. On the other hand, there's also substance use disorder and misconduct in the bottom left because those do play in. We'll talk later about some cases how they have one or both of these things at the same time. What do you do? If the dysfunction is due to a substance use disorder, you give them treatment first and foremost. Insert substance use disorder here does not mean ADSEP that day. You initially begin with a trial of treatment, refer to ASAP for an intake, whether it be alcohol or whatever. There, you assess their ability to return to service in the future. But eventually you might run into a problem of the continued rehab being unethical, impractical, or maybe not in the best interest of the U.S. military. We wouldn't necessarily want somebody who's on their way to their 4th residential, for example. That alone might qualify. There are other different provider discretion moments you have to make along the way. We should give them a trial of treatment, see if they continue and complete treatment. There's also cases where people go to treatment and then do not continue or do not meet the expectations during treatment. For those of you who rotated at Fort Belvoir, sometimes service members do not graduate from that program. Sometimes a decision is made for them to leave the program early as a treatment failure. It's a very harsh word, but that might be what's used. In which case, administrative separation appropriate for chapter 9 in particular, which was once called for treatment failure, might be appropriate. And last but not least, misconduct. Command set under chapter 14. So that's the criminal activity, misconduct, whatever it may be, UCMJ or criminal offenses, etc. So you can use this flow sheet later on when we're going through things. In fact, I'll drop this flow sheet in the group me along with the Navy version of this flow sheet for later on when we're running through cases, so that if you need to, you can pull it out on your own and make some decisions. Good.
So so looking at this flow sheet, I'm having a hard time conceptualizing why monthly inpatient unit for the really severe cases like the anoxic brain injury from the hanging, who left the unit and is there for months, and we don't initiate the med board on the inpatient unit for someone who we know has zero chance to return to service, under the dogma that only the outpatient psychiatrist initiates the med board. And I'm not really understanding from this how the continued involvement of that outpatient provider is necessary for the process. So I guess the question is the dogma of only the outpatient psychiatrist can initiate a med board beneficial for the military? Is that the right answer? Am I misunderstanding things?
Yeah, I'm right. I'm ready to answer your question. I'm with you at the end there. It's the only was the word. I could see a scenario where potentially an inpatient provider might be the appropriate. Say they weren't going to matriculate to outpatient continued service, like an anoxic brain injury. That sounds extreme. I don't know if it deals with the case, but I could see a case that's extreme enough. But even then, the medical board is an ongoing process that lasts for a year. So over that year, I would like having some continued follow-up and care. And if someone was admitted at 4 North, for example, and then discharged to an outpatient provider here at Walter Reed, which is their current duty station, if I had a choice, I'd consider the outpatient provider potentially being more appropriate, even though you would want to diagnose it inpatient. I can see that. I can see both sides. I think to answer your question, it's potentially beneficial for both, making the right choice. I would never say never to inpatient starting a med board, but I don't think I've ever actually started it. I've written 3822s implying that, and I've called command and talked about how this might be in their future, but I haven't started.
Once you place the med board, what should you expect, like, as a follow-on questions and involvement that you have to make?
And it sometimes also, especially in this area with the amount of different spaces, clinic personnel that we have, that sometimes is a barrier. So if we have a Navy person, for example, at 4 North, and we place the NCC, we essentially lock that person to our base. So they cannot move, they cannot do it's not CTS, they cannot do anything, they've now been flagged.
So sometimes it's purely out of get them to where their home station is, their home base, where they physically need to be, and then a provider can lock them in there.
Makes a lot of sense.
And each base has its own PEB, MEB office, thus they need to be initiated at that base as well to be routed to the correct MEB, PEB office.
It's a lot easier for the pedal or Pueblo to follow you through that MEB and have like one point of contact. And that's another reason why you are an inpatient.
And those are all good reasons and perhaps why you're in their first effective year, those of us not initiating that way. Right, that 8 years, you don't probably know. Excellent. All right, so this is our crawl case where I'm gonna go through with it. We'll have a little bit of participation, relatively straightforward, I guess, give or take. I'll actually read this case. Later on, we'll be asking for volunteers. So 23-year-old active duty U.S. Army specialist, 3 years time in service. He's a communication specialist, 25 uniform. He has a history of deployment, past psychiatric history of ADHD and generalized anxiety disorder. 12 months due to anxiety work. Also due to his ADHD, patient makes frequent mistakes. The command team is considering administrative separation for poor work performance. Third member also reports concerns related to family well-being, pending an unaccompanied assignment in Korea, which means he'll be going to Korea while his family stays here. He has completed IOP for generalized anxiety disorder 6 months ago, continued with therapy since. His generalized anxiety disorder is well controlled. It's arguably not the concern that he has today, and he doesn't think it's actually impairing his ability to have functional work. ADHD, on the other hand, you're having some trouble. 3 different ADHD medication trials, only mild symptom relief. The problems at work are forgetting things, forgetting security clearance items, leaving them in place that they're not supposed to be, leaving documents like right, things of that nature. Commands express concern with I can love gender in there, I'm sorry. Ability to rely on the service member to do their duties. What are your recommendations for the commanders? Go ahead to the next slide, because I wrote them out for you. But this is the topic, this is what you're gonna get later for cases, and then we're gonna ask you that question. Here's what I thought through. In the end of it all, I stopped at the top left of that diagram, and I went down until I found the condition that's limiting disorder. Because yes, GAD is on the case, but in this case, in remission. Generalized anxiety disorder is well treated, tolerating well. It's the ADHD that I'm determining is the source of the duty impairment. Diagnosis of ADHD. Next, impairment, I would say yes, so I can just be clicking next. Command teams concern related to work mistakes, some of the ones I described for you just now. Chronic, yes, it's a chronic condition, it's been going on long enough. And then prognosis with respect to their ability to return to military service explicitly. I'm not saying I think this is terminal ADHD, I'm saying I don't think the return to full duty limitations within 12 months. So I say 4. And the trial of treatment, yes, 12 months of therapy, 3 medication trials. So what would I recommend? My plan would be administrative separation, and I talked to Matt about that. And in the end of it all, command may or may not follow that recommendation. So it sounds like they were already thinking that direction. Go ahead, polls. What are your questions? What are your thoughts?
So if you have a reviewer who, the surface level review of documentation, you make a change on this, factoring the GAD just in their chart, right? So it would behoove you to
Really thoroughly document what you were saying about in remission, clearly show in your note where they do not meet criteria for GAD and how there is no job limiting impairment. And then also still be ready to write a memo about how GAD is not affecting them currently. Because just having that in, they will just stop. They'll just stop and say, nope, good try, like better luck next time. So just be really clear in your documentation.
I jokingly say the burden of proof is on you to say there is not a medical condition. So in this case, I would have to document just like you're saying, I have to be cautious and being the outpatient provider, who they then can reach out to me later and say, hey, we're reading your chart, we don't think you're acceptable because of generalized anxiety disorder. I would then write. Any other comments before we move on?
This is way off, but this is one of the reasons why not only do we have to know all this stuff, but we have to be good clinicians. So this could be anxiety, right? That's causing his dysfunction. And so you also want to always check, because we don't deal with diseases in psychiatry. We deal with disorders. So whenever you're trying things and they're not working, always reconsider your diagnostic approach, or however you do clinical formulation, because we're talking about people's careers and livelihoods. So that's another thing to consider as you go on this journey. I would say that it's I've never seen an ADHD ADCEP before. Technically you can do it, but they're not that common where people get ADCEP for ADHD. Because most of the time you get it under control. So
These are all great points. In fact, I'm going to answer these questions by going to the next slide, showing you the next prompt. Because that's exactly what we have here. It's the exact same case. The only change is concerns of the anxieties impairing their ability to use from day to day. So yes, I agree. For this, there is some standardization to these cases. We take it at face value. Assume all interrogations occurred, and you decided that last time it was ADHD. This time it's anxiety. So how does that change our recommendations? Because they've got this upcoming bonus transfer. Go ahead, just next slide to the end of the drive. So now we say generalized anxiety disorder is the source. They are having impairment, similar impairment described, and also we're concerned if the PCSO bonus are going to decompensate further. So it's chronic, it's 4. The command is coming to us saying, hey, should we ADCEP? And we're saying, well, maybe, perhaps not. Go ahead and click next. In this case, we're now recommending medical board starting from the profile specifically related to the anxiety disorder. So the key learning points between sharing these two cases with a couple things. One, that my goal was that someone could have a med boardable condition and still get access. But realizing that most likely the burden of proof and the way that everything is framed, having a med boardable concept or diagnosis on the chart is going to make a lot of logistics and perhaps more than so. So you have to be sure in your assessment and plan before you make the decision. Doesn't mean necessarily just get a med board just because somebody diagnosed with generalized anxiety disorder 4 years ago. And you never see that once in your office, for example. Right? Okay, so that's the end of my briefing, and kind of my initial presentation. We'll take a break and then we'll run through the US Navy presentation. Go ahead, sir.
Leave that there. All right. Group participation time. And I'm gonna give you cookie points. All right. So, question. So I am writing a temporary e-profile for depression, the patient's suicidal, and I want to make sure that they don't have access to firearms. How many signatures are needed for that temporary profile? All right, one, right? So, okay. Now I am referring this patient that we just talked about, the 25 uniform, referring them to med board. How many signatures? 2. Okay. Now we alluded to, and Loxley, you are what I'm shooting for, okay? In terms of the level of teaching, all right? Air Force intern. So in terms of, I go into e-profile and I type in the profile, and this is going to be a permanent profile. So we talked about 2 signatures, right? And then at each location, there are different people that have second signature authority. So you'll figure that out whenever you PCS, figure out who that person is. And always, I tend to usually discuss the case with them and say, hey, you've got this case incoming. This is my rationale for why I think they're at MRDP, or medical retention termination point. So we are deciding on the Pulleys system, right? So in the Army profile system, for temporary, we don't care about the Pulleys system, but for the permanent one, there's a Pulleys system. So PULES, right? Or HES. What does that stand for? We're shooting for Air Force level again. So P is physical, U is for upper, L is lower, H is head, E, eyes, and S is what?
Psychiatry.
Yes, so the P is, yeah, so S is psychiatric. Now he said S3, right? Why not S4? So now this is beyond Air Force intern level now. So S4, who would get S4? Yeah, which patient would you say this patient needs an S4 profile rather than S3 profile? So schizophrenia, probably group home, people that need constant, right? So can think of like someone with severe TBI who are completely dependent on someone. So someone who needs 24/7 care, essentially, think of those. Everybody else gets an S3 profile. So when you hear the term S3, that's what we're talking about. In the Army, you they call permanent profiles that are 2, right? So have you guys heard of P2 profiles? Right? How many have you done when you're a GMO? 1 million probably. Yeah, so those are conditions that we think that the Army is willing to accept, but we're not going to bother with it. You have a back problem, you're going to get a, permanent L2 profile, and we're not going to bother with anymore. You're found fit, right? In terms of retention. So those are some of the caveats with that. Now, we're gonna zoom out a little bit, a few other points. So there are ways to get people out of the Army. We're talking about Army now. Because they're not able to do what we're asking them to do, right? So there are legal ways to get people out. So if you are doing some sort of misconduct, you could get out on which chapter? 14, right? So that's a legal way out. There's also judicial, right? We talked about NJPs in the Navy, Marine Corps, non-judicial, or there's judicial punishment, so people can really do something big in terms of a crime, and then they could end up court-martialed, etc. So those are that. Then there are administrative ways of leaving, and we talked about some of the administrative ways. For example, let's say that you have family problems and it just makes it impossible for you to do your soldier duty. There are ways to get those soldiers out too, not having to do with adjustment disorder or anything like that. Then there's the adjustment disorder acute, and then there are medical channels to get people out, and that's where the medical board comes. So what are the 4 questions you need to check off in order to say someone is at MRDP and they need a permanent S3 or S4 profile? What are the 4 questions? So impairment, someone has impairment. What else? They have a medically boardable condition. They've had sufficient treatment. And prognosis, so those 4 boxes on the algorithm. So really, it's just 4 questions. Which of those 4 questions are the ones where you get paid the big bucks? So sufficient treatment and the prognosis, right? You could have someone, a computer algorithm can spit out the other 2. But so what is sufficient treatment? There might be civilian providers in the virtual world. And one of the hardest things for them is, what is sufficient treatment? So it's essentially 2 or more modalities, evidence-based modalities, right? So the threshold is fairly low for that, but obviously use your best judgment. That's where you get, so if you end up reformulating the case and you're like, I don't think this patient had that, they have this other condition, then you might be back to square one. And then the 12-month prognosis is completely your clinical opinion. So this is it, just 4 questions. Do they have medically boardable condition? And pretty much everything in DSM is medically boardable, with the exception of personality disorder, substance use, and some of the other things, ADHD, paraphilias, and acute adjustment disorder. So that S3, S4, we talked about legal channels, we talked about 4 questions, we talked about signatures, and we talked about what is sufficient treatment. Okay, someone had a question there. Kevin?
If someone has patient addiction within a close time table, do you really need to wait until the 2 treatment modalities or initiate and then right in there?
Say your question again.
So if they're requiring elevated level of treatment within a close time frame, do you really have to wait until the 2 treatment modalities to initiate that?
So let's say you send someone to IOP, like right away they show up in crisis, they're really sick, they're suicidal, and you don't think they're safe. You put them in IOP, they do 4 weeks of IOP, mood, and then they realize they have trauma, so they put them in the trauma track. We're talking about our IOP here. So now they have 2 months under their belt for IOP, but then they say, you know what? We need to send them to an RTF. And at that point, it's really clinical judgment whether you want to wait or not. There's some pragmatic things. So for example, if someone ships off to an RTF, at minimum, they're gone for 30 days. If you submit them for a med board, then the PEB office might be waiting for them to come back to sign their paperwork, etc. So you might want to wait until like the last week. see how they're doing, or you might wait until they're back. In the Navy, it gets a little fuzzy with limb dues and how many, attempts you get, and you really got to be calculated in terms of when you initiate those. But in the Army, it doesn't really matter. Other questions? Okay, so we're gonna hit this again with the Navy, and as you'll see, the processes and some of the actions are different, the language is different, but in terms of the philosophy, it's the same 4 questions essentially. So it's a very similar approach. The last thing I would say is wherever you go, there tends to be stylistic differences in terms of interpretation, expectation. So when you go to a new duty station, figure out what those are, and then you can reverse engineer your approach to make sure that, that you're supporting your MEB PEB office in terms of what they need in order to do their job. All right, thanks.